Good afternoon, everybody. Hope you can all hear me. Welcome, participants online. This is the 100th ECHO session. As we are all aware that this project is with collaboration from the Ministry of Health, but also with the Emergency Care Association of Uganda. So welcome, participants. This is going to be a fun interactive session. Like our sessions have been in the past, we're going to have a simulation scenario right in front of us. And the theme for this week is an approach to severe respiratory distress. Back at our facilities, we have patients who come to us in respiratory distress. We're going to present a simulation in front of you. We shall manage the patient like we would back at our facilities. And after that, we shall have discussion. I'm going to introduce the team right in front of me. I'll start off by introducing myself. Doreen Okong Alaleta, my name. I'm an emergency physician. I'm an educator at Makerere University through the SEED Global Health Program. I will ask the team to introduce themselves.
I'm Paul Sekate, an emergency medicine resident, year 3, Makerere. Thank you.
Good afternoon, everyone. Welcome. My name is Rebecca
Good afternoon, everyone. My name is Sergeant Junan. I'm an emergency medical technician.
Good afternoon, everyone. My name is Angel Kanyange Maureen, and I'm emergency nurse. I'm glad to be here.
Online, we have our expert, Dr. Ori Badan. Please unmute and introduce yourself to the viewers.
Thank you very much, team. My name is Dr. Dan Orivala Moya, an internal medicine physician and also an honorary lecturer in the Department of Internal Medicine in Gulu University. I'm happy to be here. Thank you.
Okay. So Dr. Oriba is going to be the chat questions. Participants online, feel free to send in your questions. And Dr. Oriba will handle them. In the meantime, let's prepare to start our simulation. Okay, so we'll start off by let's display our PowerPoint presentation for the audience. This is not working. Like I'm hearing myself, then I'm hearing myself, then I'm hearing myself.
So let's disconnect the audio connection.
So now can I talk?
Yes. Just talk like that thing is in front.
Yeah.
All right, team online, can you hear me? Put a thumbs up. Hope we're loud and clear. Like we said, the theme for this week is an approach to an adult patient with severe respiratory distress. All right. So right in front of you, we're going to give you a summary of what the case is about. All right. So these are the learning objectives. At the end of this simulation, we should be able to recognize the risk factors and presentation of severe respiratory distress. How does a patient present to you in respiratory distress? We should be able to stabilize a critically ill patient with severe hypoxia and shock. These patients come to you and they're oxygen deprived. What oxygen saturation are we aiming for? How do we recognize hypoxia? How do we manage shock in these kinds of patients? We're going to go through a stepwise approach on how to deliver oxygen. What are the modalities that we use? What are the indications? Back in our facilities, we have nasal prongs, we have simple masks, we have non-rebreather masks, we have high flow modalities. So when do we use what and why do we use them? Then we also need to make very timely, critical decisions when we're managing patients with respiratory distress. I know back at our facilities, We need to make decisions on which patients do we stay with and which ones do we refer, and then where do we refer them to. Also, we're going to demonstrate, because it's a simulation, how to work in a team. In the practice of emergency medicine, teamwork is very important. You never resuscitate a patient by yourselves. It's a team effort, and there are non-technical skills that this team is going to demonstrate. Team dynamics, team communication, leadership, resource allocation are part of resuscitation. So those are our learning objectives. So what is the simulation about? We have simulated a case, and this case is about an adult male. He's going to be called Mukasa John, 45 years old. He's an obese man. He drives a truck. He's a non-smoker. He's hypertensive. And we're simulating that he was being managed at Ginger Regional Referral Hospital. So high five to the Ginger team. This was your patient. He was being referred to Mulago National Referral Hospital for advanced care. What were the symptoms that he presented with at Ginger? He had severe shortness of breath, and this was getting worse over a period of 3 days. Important to note is that while at Ginger Hospital, he had previously been admitted where he had surgery done to repair a pelvic fracture, and this was done 1 week ago. So after the pelvic fracture, he was discharged home, where he then developed difficulty in breathing, and this difficulty in breathing was associated without any chest pain, and there was no fever. So I hope we're getting the story now. Adult male, non-hypertensive, non-smoker, post-surgical patient, initially admitted, surgery went well. However, he went home and then developed difficulty in breathing, right? Okay, so we'll start off the simulation with the ambulance team arriving at Mulago Hospital, where they are going to hand over the patient to the clinical team. However, before we start the simulation, you have a poll in front of you. Whenever a patient is being transported and there's a handover process in place, what does the acronym ISBAR stand for in clinical communication? So what do we think? Is it option A, option B, option C, or option D? All right. ISBAR is an acronym when we're going to hand over patients. This handover can take place inter-facility. It can take place intra-facility. It can take place from the ward to the ICU, from the ward to theater. It can take place during a shift change. I'm seeing there is a poll between option A and option B. Okay, so we're about to close our poll. Okay, so majority of us have answered option B, which stands for identify, situation, background, assessment, and recommendation. And that is the correct answer. When we're going to hand over a patient, we should identify ourselves, identify the patient, set the situation in front of us, give a brief about the background, what we did in the assessment, and then why we are going to hand over this patient or we are going to refer this patient. So congratulations for those who ticked option B. That is the answer. All right, team, let's prepare to start our simulation.
Yes, I am. Please, sir. Hello, good afternoon.
Good afternoon.
Yeah, my name is Kenan. I'm a paramedic, Minister of Health. With me, I'm having a 45-year-old gentleman by name of Mukasa John, who is a referrer from Ginger Regional Referral Hospital. And he's a non-hypertensive patient, heavy smoker. He was discharged 1 week after undergoing pelvic surgery, and he was discharged. So 3 days back, he presented with shortness in breath, which has been deteriorating. So at the referral, they were able to manage with a non-rebreather mask, oxygen. They were delivering 15 liters of oxygen, and that's how we have brought him, maintaining the 15 liters. He has been deteriorating to 80 to 85%, but then we maintained the non-rebreather by just positioning. He was having some hypotension, which we managed with one bottle of normal saline because we are suspecting obstructive shock.
What was his blood pressure?
The blood pressure was 80 over 50 millimeters of mercury. Yeah, so at Ginger Referral Hospital, they weren't able to do a chest CT scan. They are suspecting pulmonary embolism, but they couldn't do a chest CT scan. So it is one of the main reasons why they are referring.
Okay, any medications that have been given so far?
Actually, we didn't give any medication. We just gave oxygen and one bottle of normal saline.
All right, so I'll take over the referral form. Thank you
Okay,
so
for
much.
staying there.
Okay,
Okay, thank you so
thank
much.
you. All right. So I'm going to do a primary survey on this patient. Mr. Mukasa.
Oh,
Mr. Mukasa.
oh, doctor, Mr. Mkasa is talking to you, but they are short sentences.
All right, so I'm going to assess him using a primary survey using the ABCDE. So looking at our airway, assessing with the look, listen, and feel. When I look, is there any cyanosis?
There is no cyanosis.
And when I look into the mouth, any secretions, any obstructions?
No secretions, no obstructions.
Any facial deformities?
No facial deformity, no swelling.
All right, so Mr. Mukasa,
Doctor,
so he's able to talk to me, so his airway is patent. I'm going to assess his breathing. When I open, I assess for respiratory rate.
he's breathing at a rate between 30 to 35 breaths per minute.
Okay, then when I look at is he using his accessory muscles?
He's in severe distress. He's using neck muscles and abdominal muscles.
Chest expansion, is it symmetrical?
Yes, symmetrical chest rise.
All right, our trachea?
Trachea is midline.
Midline, okay, so when I auscultate for breath sounds,
When you auscultate, normal breath sounds equal air entry, normal breath sounds equal air entry.
and then I do some percussion.
Normal percussion, normal percussion, normal percussion, normal percussion, normal percussion.
Okay, so I'm going to do an SpO2. When I touch my SpO2, what's my reading?
When you attach your SpO2 and switch on the monitor, he's at 85% with a non-rebreather mask.
Okay, so 85% on a non-rebreather mask. It means that most probably are going to require an advanced airway. Dr. Rebecca, Dr. Paul, please, I need your help. I need your help.
Yes, Andrew, how can we assist?
Okay, so we have this referral from Ginger Regional Referral. He is a 45-year-old, non-chronic smoker and non-hypertensive patient, was brought in with suspected pulmonary embolism. We are saturating at 85% on a non-rebreather mask, hypotensive with a BP of 80 out of 50. However, I failed to get his oxygen saturations up, and I'll require your advanced management for the airway. Kindly help us.
Right. So is my scene safe to approach?
It's safe for you to approach.
I'm going to put on my PPE, put on my mask and apron, and expose the patient. When I look at the patient, I'm going to repeat a primary survey for this patient. When I look at their airway, do I have any secretions, any foreign body, any cyanosis?
No secretions, no foreign body, no cyanosis.
Mr. Mukasa.
Doctor, he talks to you but in short sentences.
So he's able to vocalize and the airway is patent. When I look at the neck, is there any swelling?
There is no swelling, there is no deformity, no tenderness.
I go ahead to assess breathing. What's the respiratory rate of this patient?
He's breathing between 35 to 40 breaths per minute.
Any symmetrical chest expansion?
There is symmetrical chest expansion.
When I palpate the chest, do I have any deformities,
There is
any
no-
tenderness?
No deformity, no tenderness, no crepitus.
Okay. When I percuss, do I have a good percussion note?
You have normal percussion note in both the left and right.
Okay. When I come to assess his trachea, is it centrally located?
The trachea is centrally placed.
Right. So I'm going to go ahead to auscultate.
no more breath sounds, no more breath sounds, no more breath sounds, equal air entry, no more breath sounds.
Okay, Angel, what's the SpO2 of this patient?
SpO2 is still at 85%.
Dr. Sekate, would you come and connect a high flow nasal cannula for our patient?
Okay.
The NRM is not providing sufficient oxygen for our patient.
So team, let's stop for the poll question right here. So members online, there's a poll question in front of you. Okay, which oxygen delivery method would be most appropriate to initiate at this stage? As you can see, the patient came in with a non-rebreather mask, but the options in front of you, we have a CPAP, a simple face mask, or nasal prongs. He came in at a respiratory rate of 35 to 40 breaths per minute, and his oxygen saturations are at 85%, despite being on 15 liters. So which of these four would you now choose to escalate oxygen delivery? All right. We have CPAP, we have simple face mask, nasal prongs, and high flow nasal cannula. We are going to end the poll shortly. It's in between CPAP and high flow nasal cannula. Okay, 40% of us have picked CPAP and 45% have picked high flow nasal cannula. 8% have picked a simple face mask and nasal prongs. We shall end the poll. So the answer for this patient is we shall escalate to high flow nasal cannula. A simple face mask is actually de-escalating, it's lower, we only give 10 liters. Nasal prongs is also lower, we only give 5 liters. As CPAP, we only maintain it for conditions where we have pulmonary edema and we want to cause expansion of the alveoli. For this particular patient, his chest was dry, it's not wet, so he actually does not need CPAP, right? He needs high flow nasal cannula, right? So let's move on with the simulation team.
Okay, high flow nasal cannula connected.
All right, let's proceed to assess the circulation. When we palpate his palms, what's the temperature of the palms?
The palms are cold.
What's the capillary fill?
Capillary fill is 5 seconds.
How is the pulse rate?
Pulse is rapid, it's about 180 beats per minute.
When we look at the veins, neck veins, are they distended?
They are not distended.
Go ahead to auscultate for heart sounds.
No more heart sounds, no more heart sounds, no more heart sounds, 1 and 2, no murmurs.
And what's the BP of our patient?
It's taking.
Right. So in the meantime, can we connect ECG leads for our patient?
Okay.
When you connect the ECG leads, you have a sinus tachycardia, you have a pulse rate of 180 beats per minute.
All right. So we are going to go ahead and perform a cardiac focus for our patient.
You have normal lung sliding on the left and right lung zones.
Right. Do we have any signs of pneumonia?
So you don't have any B lines, there's no sign of pneumonia, there's no sign of inflammation.
Do we have any signs of an effusion?
There's no effusion on the left, there's no effusion on the right.
When we look at the IVC.
IVC is not collapsible and the diameter is about 2 centimeters.
When we look at the heart
is hyperactive, you have right septal deviation, and you have features of right heart strain.
Team, our patient has signs of pulmonary embolism, right?
Yes. Yeah.
So Angel, you're going to connect a bolus of fluids, that's 500 mils, but let it run really slowly.
Okay, also our blood pressure is reading at 80 out of 50.
Okay, team, let's pause for the poll question right here. For the poll question. Members online, there's a poll question that's going to come up in front of you. We want you to interact in this session so that you take part in the decision making. Okay. So this question is what the team just performed a point of care ultrasound. What is the clinical role of performing a point of care ultrasound for this particular patient? Is it to diagnose the pulmonary embolism? Is it to diagnose and grade liver injury? Or is it to diagnose aortic aneurysm? So we have to diagnose pulmonary embolism. Is it to diagnose pulmonary edema, or to diagnose grade liver injury, or to diagnose an aortic aneurysm? What do we think is going on in this patient? Please remember the history. Please remember the presentation of the patient. What do you think is going on in this patient? And why do you think the team went ahead to perform a point of care ultrasound for this particular patient? All right, so we're going to close the poll. And majority of us picked the right answer, which is to diagnose a pulmonary embolism. This patient does not have features of pulmonary edema, but it can also present with respiratory distress. However, his chest was clear. This patient does not have features of liver injury. There was no history of trauma. When he came in, he's in respiratory distress. Liver injury would have other features like altered mental status, change in color, etc., etc. Neither does he have features of an aortic aneurysm. So our correct answer is a pulmonary embolism. All right, team, let's continue with the simulation.
So Dr. Sekate, we have
Yes, please.
confirmed the pulmonary embolism in our patient. Please call cardiology so that they can come here and support us.
Okay.
So in the meantime, let's process to assess our disability. What's the RBS of our patient?
RBS is 7 millimoles per liter.
What's the BCS of our patient? Mr. Mukasa,
So Mr. Mukasa is confused. However, he opens the eyes spontaneously and obeys command.
Right.
Cardiology is coming.
Right, thank you, Sekate. When you look at his pupils,
Pupils are equal and reactive to light.
right, so we go ahead to assess his exposure. When we expose him, what's the temperature of our patient?
The temperature is 36.8. There are no rashes. There is no swellings, no deformities.
How is the pelvis? Is it still stable?
Pelvis is slightly tender because he previously had surgery while in Ginger.
Dr. Rebecca, I took off some blood samples when I put a cannula. Which test would you like me to
All
order?
right, you're going to do a CBC, LFTs, RFTs, D-dimers, and cardiac biomarkers.
All right,
And then ABG as well.
Let me rush this to the lab.
All right, so let's come back and reassess our patient. What's the airway like? Do we have any secretions in our body? Is it still patent?
The airway is still patent, no secretions.
All right, go ahead to assess breathing. What's the respiratory rate of our patient?
He's still breathing at a rate of 30 to 40 breaths per minute.
Wow. What is the SpO2?
Our patient is still saturating at 85, now down to 80%.
Down to 80%. Can you auscultate?
When you auscultate, there is no more air entry, no more air entry, no more air entry, and no more breath sounds.
Just a second.
Okay.
You're going to manage the airway and you're going to prepare for intubation.
Thank you.
Right?
Let me do the machine check. In the meantime, Angel,
Yes, please.
can you prepare for me the medicines that I'm going to use? I'll need midazolam, ketamine, sax, and fentanyl. Okay, let's have them ready so that we can have very good intubation.
In the meantime, we're going to go ahead and assess for circulation. When we look at our palms, what is the temperature like?
Hands are cold.
All right, what's the capillary field?
Capillary field is still 5 seconds.
All right, pulse rate?
Pulse rate is tachycardic at a rate of 180 breaths per minute.
What, any distended neck veins?
There are no distended neck veins.
Auscultate for heart sounds?
Okay, so there are normal heart sounds 1 and 2, normal heart sounds 1.
What's the BP like?
BP is still 80/60.
Angel,
Yes,
the patient is not responding to fluids. At this point, let us start vasopressors, start an adrenaline infusion.
All right, team,
Okay.
let's pause before we move on. Let's look at the screen. Members, we are going to put up a poll question for you there. So this patient is on high flow nasal cannula and he's not improving. On high flow nasal cannula, our sacs are still at 80%. He's still breathing very fast. So now, which advanced respiratory management option would you want to use now? Should we continue with the high flow nasal cannula? Should we plan to intubate and place the patient on mechanical ventilation? Should we give oral bronchodilators? Or do we encourage him to take deep breathing exercises with a non-rebreather mask? This patient came from Ginger. We've escalated from a non-rebreather We've moved to high flow nasal cannula. It's still not working. What would be the next step to ensure that he improves on his saturation? Members online, we want you to take part in the decision making. This is a patient who has a high flow nasal cannula. He's getting about 60 liters of oxygen. He's still in severe distress. He's still hypoxic. What would you want to do at this point? All right, we are going to close the poll. Let us end the poll. Good. So majority of us have actually picked the right answer. The right answer is now we move to advanced respiratory management, which is to intubate and place him on mechanical ventilation. So that is the stepwise approach that we are trying to achieve for this particular patient. All right, team, let's continue.
Okay.
Are you ready
We are ready to
intubate?
intubate.
Right, the noradrenaline drip has been put up.
Okay, thank you, Angel. We
Okay,
need
the
that
drugs are also
noradrenaline.
ready.
Okay, so give fentanyl,
All right, fentanyl,
100 micrograms.
100 micrograms given,
Okay,
and flash.
okay, great. Give me dazolam,
All right, so midazolam,
4 milligrams.
okay, 4 milligrams given
Okay, then give
and
ketamine.
flashed. And then also ketamine,
Yes.
100 milligrams given and flashed.
Okay, great. Now we take away whatever was put under the patient's head to support him, and we are ready to. So we are pre-oxygenating our patient with oxygen. What is our saturation?
Our sats have gone up to about 88%.
Okay, looks like we may not go past the 88 with our ambo bag. I think, Angel, let's prepare to intubate the patient.
Okay,
Okay.
So right now,
Give saxamethonium.
all right, sacs given,
Any fasciculation seen?
we can see fasciculations.
Okay, thank you. Give me the laryngoscope. Great. Okay, I can see the vocal cords. Give me the bougie. Slide the ETT over the bougie. Okay, my ETT is in. I've confirmed by looking at the vocal cords. Great. Take out the bougie. Cuff. Okay, let's bag our patient. Dr. Rebecca, confirm
No more air
placement.
entry, no more air entry, no more air entry, no more air entry.
Okay,
Our sats have also gone up. They are currently at 92%. Our heart rate has also dropped. It's at about 110.
okay. So let me secure the ETT. Securing our ETT at 22. Yeah, ETT secured. Angel, help me with the connector. Okay, our patient connected to the ventilator.
Okay, so oxygen has been delivered through the ventilator. FiO2 is at 100%. SpO2 is at 92% for the patient, and our vitals are much better. All right, team, what's the next step you want to do for this patient?
We are going to reassess our patient and perform a primary survey for the patient.
Okay, so in terms of disposition, you have intubated the patient, you have stabilized the patient, you've given vasopressors. Where would you want to take this patient?
Right, our patient will need to be taken to the ICU.
All right, so prepare to do a verbal handover to the ICU team.
Thank you.
Hello, doctor.
Yes, please.
All right, this is Rebecca, the physician at the ED.
Yes, Dr. Rebecca.
All right, I'd like to inform you about a patient that we need to bring to the ICU. He's a
Okay.
45-year-old male. He's received from Ginger Regional Referral Hospital. He's a non-hypertensive, a non-smoker who had surgery for the pelvis 1 week ago. Presented with a 3-day history of progressively worsening difficulty in breathing. On arrival, he was in significant respiratory distress on non-breather mask and also in shock. We escalated oxygen delivery devices from non-breather to high-flow nasal cannula, and we have now intubated him. He's connected to the ventilator on mandatory mode. Sats have improved. He's currently saturating at 92% on mandatory mode. He's also on vasopressors, noradrenaline infusion. Our focus revealed signs of a pulmonary embolism. We think the patient needs to be transferred to the ICU, and also the cardiology team needs to come in and assess for thrombolysis.
Okay, thank you, Dr. Rebecca. Please prepare to bring the patient. The bed is being set up in the next 5 minutes.
Thank you, Doctor.
All right, team, let's stop the scenario right there. Members online, we have completed our simulation. The team has managed the patient. Patient has been taken to ICU. So thank you, the team from Ginger, for referring the patient. Thank you, the team from Molango, for managing the patient. So right now we're going to have a discussion and debrief the team. So team, please come. Yes. Members online, can you hear us loud and clear? Remember that the theme for this week is an adult patient in respiratory distress. What do we want you to learn? We want you to learn to recognize respiratory distress. We want you to learn when to refer a patient with respiratory distress. We want you to learn how to escalate management in terms of oxygen delivery for a patient in respiratory distress. So in front of me, like I said, we have a panel of experts. We have members from the pre-hospital team. We have emergency physicians. We have emergency residents. We have emergency nurses. This is a team effort, all right? So team, how did that scenario go? I will start off with Dr. Rebecca. Give us one positive about how the scenario went, and then we shall move to Jonan, Paul, and Angel. What went well for this scenario?
Thank you so much. What went well with this scenario, I must appreciate the teamwork that was exhibited. We could not have, each of us could not have resuscitated this patient individually. So teamwork played a huge role in the outcome of this patient.
All right, Jonan, what went well in this patient?
Yeah, from the part of the pre-hospital, still I will appreciate the use of ESPA because it made the work of handing over very easy. And they touched all the information from Ginger on transit and to the facility that was receiving the patient.
Dr. Paul, you're one of the doctors that managed the patient. What went well in this scenario?
What went well is that the team leader was communicating timely. So we were able to intervene timely, and we had a close loop communication. So communication back and forth, which made work easy for us.
Okay. Angel, you are the emergency nurse who received the patient. What went well in this resuscitation?
First and foremost, it's the acknowledgement that the nurse was able to perform the primary survey as the doctors were completing with whatever patient they were handling. So she was able to identify the life-threatening condition, which in this case was the severe respiratory distress, despite the minimal interventions done, and able to ask for help, which is one of the objectives of this scenario, asking for help and teamwork.
Okay.
So all people in the team played a role for successful resuscitation.
All right. So team, this patient had severe respiratory distress, all right? Angel, just take us through. How does a patient with severe respiratory distress present? What are the signs and symptoms of severe respiratory distress?
So this one I'm going to mainly stick to more of the adults since we're dealing with an adult patient. So usually the respiratory rate is going to be above normal. So the normal rate, we have 12 to 20. So something above 20 shows that there's some respiratory distress. And then also the use of accessory muscles. So we are using our abdominal muscles, the intercostal muscles. A person also usually positioning. If you notice, Dr. Paul kept the patient. And even when Jordan was handing over, say the patient was repositioned. So they tend to look for comfortable positions, unable to complete sentences. For some, they may present with some chest pain due to the effort in work of breathing. Then also we noticed on our SpO2, the oxygen saturation is low. If you are in a well-advanced setting, if you're able to do the ABGs, you'll notice some acidosis. So some of those are some telltale signs that we get. Even cyanosis, especially for the lighter complexion, you'll notice a lot of some blue tinge, even in the fingertips. Yeah.
So Dr. Rebecca, you examined the patient. In your examination, what are some of the clinical signs that you can elicit that can confirm respiratory distress in a patient?
So again, I like to use the primary survey approach. You come and look at the patient. Just by listening to them, we try to ask, does this patient have any abnormal sounds? They could be having a stridor, they could be having a wheeze when you listen to them. When you come down to breathing, you want to look at the respiratory rate, which was elevated in this case. You want to look at the chest, how it's expanding, is it symmetrical or not? You want to palpate the chest if there's any tenderness, any signs of maybe trauma or broken ribs in case it was a trauma case. You want to come and also auscultate the chest. Is there any reduced air entry or not? If the patient maybe has a pneumothorax or has an effusion or has added sounds, maybe they have crackles, maybe they have a rhonchi. So all those you can elicit from your physical exam. Then you want to look at their SpO2. If you have a pulse oximeter and our patient was desaturating, was at about 80% at the initial time when we assessed the patient. Yeah.
Okay, thank you, Dr. Rebecca. So you do realize that this patient came through the ambulance system. We now have regional emergency coordinators, and what these RECs do is that they coordinate transportation of emergency patients from different regions. So hi to all the RECs online. Thank you for the work you're doing. Jonan with us here is experienced paramedic. He's been in the ambulance system for quite a while. He's had experience transporting emergency patients. So Jonan, just talk us through when you have a patient in the ambulance and this patient is in respiratory distress, what are some of the maneuvers you can do to improve their oxygen saturation? Just take us through step by step what you want to do.
Okay, starting with the basics, we have this patient who is presenting with respiratory distress. One, we shall emphasize on the positioning. So we won't keep the ambulance stretcher flat. We'll have to adjust it to be more in a sit-up position. That is the maneuver. And then we try to maintain the oxygen that is being given by the physician or the referring doctor. We can get more information from the doctor if he's advising. In case there is any deterioration, you can do this. But we try to maintain the sit-up position.
Okay, so very important position, as you've heard Jonan speak. The teams on the ambulance, you can prop the patient up to improve the oxygen delivery. So back to the ED team. Dr. Rebecca, Dr. Paul managed the patient. We noticed that you accelerated and advanced your oxygen delivery. The patient came with a non-rebreather mask. The decision was then made to use high flow nasal cannula, and then later you intubated the patient. So just talk us through, Dr. Paul, what was the indication to intubate the patient? Why was that decision made, right from the high flow nasal cannula and all the way to intubating the patient?
Okay, thank you. So when the patient came in, he was on a non-rebreather. And on a non-rebreather, we were able to get his SATs between 80 to 85. which we felt was not sufficient for our patient. So we escalated to the nasal cannula and the high flow nasal cannula, which we thought that would give us better SATs at that time, but we did not achieve that. Then we as a team had to take a decision that we cannot keep our patient hypoxic in such a situation. So we as a team decided that this patient can benefit from ventilatory support. Though being a PE patient, we should have delayed ventilation, but in this case, it's the only mode that we had. So if you're in a better setting, you can always delay ventilatory support for PE cases, but for this case, we were managing the respiratory distress irrespective of the case. So we decided to tube the patient and we got better SATs. That's the reason as to why. So as you're managing your patient, keep back and forth checking your saturations. Are they improving? What is my target? If I hit my target, I maintain. If I do not hit my target, then it's important that I switch to another modality that can help me hit my SATs that I need for the patient.
Thank you, Dr. Paul. Dr. Rebecca, I noticed you kept going back to reassess the patient. Whenever an intervention was done, you'd go back and reassess. Why is it important to reassess our patients, especially our emergency patients, as we're doing the primary survey?
Good question. First of all, we reassess to try and see if our interventions have actually worked. For example, if I come back to the patient here, in this scenario, we had to come back, the patient came in with an NRM mask. We escalated to high flow nasal cannula. We had to come back and reassess and see if our patient is actually responding to a high flow nasal cannula. So I had to come back and re-examine the patient, looking even as well as their SpO2 to make a decision that, you know what, we need to now escalate. There also might be other signs that we might have missed. So you have to always come back and reassess. Something might change in the airway as you've finished you assess your primary survey up to E. But when you come back and reassess, you may be able to figure that out.
Okay, thank you, Dr. Rebecca. There was something else about this patient. This patient was in shock. This patient had a pulmonary embolism. So, Dr. Sekati,
Yes.
take us through what are some of the things that guided your clinical decision to confirm pulmonary embolism in this patient. Then Dr. Rebecca will guide us on what were the clinical decisions that guided your decision in shock for this patient. So we'll start with Dr. Sekati.
Okay, thank you very much. So when the EMT handed over the patient to our nurse, he was able to give her very important history. And right from the history, that's where we started doing our deductions. So our patient has history of smoking. Our patient has history of surgery 1 week ago, where a pelvic surgery where he was discharged, and we do not get the information about his discharge treatment. So we don't know whether he was discharged on any, on rivaroxaban, we don't know. So he goes home, 3 days later, he comes back to the hospital with respiratory distress. So that already, and also the patient being obese is another risk factor. All those are things that you come looking at, and then you start drawing your deductions. And then when we go on to examine the patient, we did the cardiac focus. So when we did the cardiac focus, we saw that our patient had an RV strain, which is also one of the confirmatory tests that we look at in case we are to confirm that our patient has a PE. Secondly, also our BPs were driving us towards that. And we think our BPs were low because it was an obstructive type of shock, which is very common in PE. So basing on that, basing on the SATs, basing on the parameters that we had, that's the BP, the saturation, and the heart rate, we were able to deduct as a team that our patient has a pulmonary embolism.
Okay.
Yeah.
So members online, early recognition of a critically ill patient is very important because the earlier you refer the patient, better outcomes for the patient, right? So Dr. Rebecca, take us through what guided you to make a decision that the patient was in shock.
So on the initial assessment, one, his palms were cold to touch. His capillary refill time was 5 seconds. His blood pressure, he was diaphoretic. His blood pressure was also low, 80 out of 50. Notably, he had received fluid prior to arrival. We gave another bolus of fluids as we were assessing him. We came back to reassess him during our second primary survey, and he was still not responding to the fluid administration. On top of that, we did on our examination of our point of care ultrasound, he had signs of pulmonary embolism, which is a cause of obstructive shock. Adding him more fluids would actually not help him at all, actually be more detrimental. So that guided our decision to escalate from just fluids to now starting pressors, that's a noradrenaline infusion.
Okay, thank you, Dr. Rebecca. So over to you, Angel. Angel is an emergency nurse. As you can see, she took part in the resuscitation. Like I said, resuscitation is a team effort and you cannot resuscitate alone. Angel, just talk us through what is the role of emergency nurses, particularly when it comes to resuscitation of patients.
All right, so as we all know, the first contact of every patient is usually the nurse. And most times, if you've been to majority of our EDs, doctors will be preoccupied either performing another procedure on a patient. So it is good as an emergency nurse to do your primary survey, because at that point you realize some life-threatening conditions that may require either help from the doctors themselves or even you to intervene. So as the nurse, your role is not just to receive and maybe wait alone for the doctor. So you can do your primary survey, issue those immediate management interventions that look like they're basics, but these may be the ones that probably are life-saving for your patient. Another thing is during the resuscitation, as a nurse, majority of the times you're going to need to have your medications ready. At times, you also might be a second voice, because I think all the residents and physicians will attest that most times the nurses are the ones who are going to teach you some of how these medications are mixed, how they are used, and how they're actually given. So as a nurse, you also have to be able, when you are preparing for intubation, you have the medications out in their right dosages, and even at times you might remind the physician when some of these are missed. So these are some of the critical things whereby as an emergency nurse, you stand afar and a part of this team to create an impact. Then at the same time, you are going to be responsible for the continuous management of this patient. As they're transferring to the ICU, you're going to have to give a proper handover. And most times when you know this patient and you assisted in this resuscitation, it's easy to also hand over to the fellow nurses on the ICU ward, and even as you change over shifts. Then it helps with the transition of care of these patients. So as a nurse, it's a very important role, because majority of the times you're the one who ensures the continuity of care of this patient, and you are the biggest patient's advocate in all this. Thank you.
Well said. Thank you, Angel. I'm going to close this debrief session. Thank you, team, for participating. Dr. Oriba, you are online. I'm going to ask you to give us your presentation. Dr. Oriba Dan is an internal medicine physician. He practices in northern Uganda, and he's going to present for us, give us a small discussion in regards to an adult patient in respiratory distress. So Dr. Oriba, please unmute, and over to you. Dr. Oriba, please unmute. Yes, please.
Just trying to set up quickly. Okay. Okay.
We can see. Yes, we can see your screen, Dr. Oriba. So over to you.
much. I think we are just going to have a brief overview of hypoxemia. And without wasting time, I had to put also children and adults. These are probably the physical signs and that you can get in a patient who has features of hypoxemia. In children, you have to look at things like rapid breathing, and you can see the red there. They normally also get abdominal breathing, irregular in red and depth. The chest wall, since it is thin with little muscles, you can also see that very clearly. The 7 ribs in this patient can be seen because of the strain that they are going through. Normally they have a round thorax, and their airways are also short. So when you see these features and in these patients that they are having this, you are probably want to suspect this. In adults, the respiratory rate 16 to 24 is normal. The power of the muscles in these patients are reduced. They probably have barrel or elliptical chest, and their lung tissue is less elastic, and the airway collapse is likely to occur more easily. So those are the things that you probably want to look at. So what is hypoxemia basically? Look at hypoxemia is equal to low oxygen levels. When you have SpO2 of less than 90 or even 92 and low on a pulse oximeter reading, you probably want to go to 92 so that we don't want to be so low. And the common causes are there. I think we can see it very clearly. But there are other causes, of course, which are not, I've not put here, like in medical causes, I think we are going to see. But this is more in children, and you have to look at it more critically. Now, when you look at medical conditions which are responsible for causing you this, we have pulmonary embolism, pneumonia, sepsis, shock, malaria, COVID-19 or viral infections, heart failure, and so many other things. In surgery, you're also looking at trauma patients, probably chest wall trauma, head injury patients, and so many other things. Cystic fibrosis, anesthetic accidents. In obstetrics and gynecology, you put an emphasis on obstructed labor, patients with ruptured uterus, maternal factors that compromises placental perfusions, especially preeclampsia and eclampsia, and also in patients for cesarean section because you want to monitor them. In neonates, I've extracted this clearly from their book. They have birth asphyxia, respiratory distress syndrome, severe sepsis, and transient tachypnea of the newborn. So these are the common things that you find. And by the way, it is well written in Ministry of Health booklets. What about the clinical signs that are specific and probably you shouldn't miss? Like in children, you want to look at blue coloration of their tongue, gum, what we think central sinuses. You want to see, are they grunting? Are they head nodding or bobbing with every breath? So that are there features of nasal flaring? This normally tells you that there is severe respiratory distress in this child. You also want to look at the lower chest wall, if there is chest wall indrawing. You want to count their respiratory rate. You want to look at depressed level of consciousness using either the AVPU scale or the Glasgow scale. And then, of course, the inability to drink or feed when the patient is breathing. So you look at again, the importance of clinical examination. You want to identify the signs indicative of low oxygen tension. You can use the blood gas analysis. I mean, this is something that is very, not very common. And of course, we need to learn how to interpret it. But what is really available to us is a pulse oximeter, and this right here is a pulse oximeter. So you need to make sure that you know how to use a pulse oximeter very well, and you see the importance of both blood gas and pulse oximeter. Pulse oximeter is readily available and is accurate. Blood gases are highly accurate, but it's expensive and less available. So I think in our settings, we are likely going to encounter pulse oximetries in order to give us SpO2 reading. So again, what about hypoxemia? When you see someone comes with saturation of 20%, you have to be very careful, okay? Because their risk of death is also 20%. And once they come at 80%, their probability to die decreases to less than 10%. That one tells you the importance of oxygenation in this patient so that you reduce their mortality. So hypoxemia can be treated by timely and adequate oxygen administration to these patients. And that is the importance of today's discussion. And we are going to look briefly on how you produce oxygen. Like this is an oxygen plant, which is, very common in regional referral hospitals. So in most regional referral hospitals, you will see this, oxygen production plan, which actually sometimes can be scaled up to wall oxygen, and also lower health facility can bring in their cylinders for filling. And thanks to Ministry of Health for the provision of this, really. In Lacho also we have this available with also wall oxygen. So these are the various oxygen delivery equipment that we have. And I think from the simulation you've already seen, these are the devices that you can use, probably oxygen devices. The pulse oximeter. I've not put a blood gas analyzer here because it's expensive and readily not very available. So you can see the pulse oximeter. You can see the oxygen cylinder, really, which is very common, and that is it's truly connected to a pressure regulator with a cylinder key, and at the same time you have a flow meter which helps you to regulate how much oxygen you put there, and then at the same time you have a pressure gauge which tells you the amount of oxygen that is left in that cylinder. So when you go to the basic oxygen delivery device, what we see here is a simple, is a nosochron, and we have seen it being used in this patient. This is a simple face mask without a reservoir. This one here is a non-rebreather mask, and you see it has a reservoir here. And then in other centers, you also have oxygen concentrators, which normally is graduated at this point, and you can vary the amount of oxygen given until about 5 or 6 liters per minute. This one here is advanced flow meter, and I'm going to show you here. Right here, we have a flow meter upon stopping my screen sharing. And at the same time, we also have mechanical ventilation. So consideration for oxygen has to be based on what is available at your facility. And if the facility cannot provide that, you have to make sure that you escalate the transfer of this patient to a facility which can do that. So this one here is your nasal cannula, this is your face mask, okay? Then this face mask with a reservoir bag, what we call a non-rebreather mask, sometimes we call it NRM. High flow nasal cannula, you can see it here. This is a humidifier. This one is connecting to the oxygen port. Of course, in some patients, this one has aerosol risk, but the good thing with this is that it offers for you high flow of up to 70 liters per minute. The one we have offers 70 liters per minute and FiO2 of up to 100. This is mechanical ventilation, normally considered the last option in our patients, and gives you FiO2 of up to 100%. So we go to the next, really. What about for children? I think I'm not going to give a lot of information here. This will be available on the platform. Neonates, really, they have low maximum oxygen flow rates that you can use to them, and that is what we can use for them. Both infants, preschool, and school-age children, we can vary it like that. Yes, so let us look at the high flow nasal cannula. A high flow nasal cannula is really a game changer, and we started using this a lot during the COVID time because we found out that patients actually require a lot of oxygen. My first time to use this was during the COVID ICU and HDU at Mulago Hospital. And it helps a lot to stabilize these patients before going straight away to mechanical ventilation, which is labor intensive and at the same time requires a lot of expertise. So this one can deliver 100% oxygen, FiO2, but also requires high level of oxygen flow, up to about 60 or 70 liters, and requires active heat humidification. So the machine does everything for you to keep the airways from drying out. It's well tolerated and probably, help this patient so much. I had to put this because it helps. It was very helpful during the COVID time. Selected patient must be awake, they must be cooperative, they must be hemodynamically stable without urgent need for intubation. And then you have to monitor them closely if there are requirements or they are going into respiratory failure, and you initiate the last step, which is mechanical ventilation. Now, I wanted to play this video for us. This has been taken with consent on one of our patients that has been on mechanical high flow nasal cannula.
So this video is taken with consent. This patient who is on high flow nasal cannula. This is the setup. It's an oxygen, comprehensive oxygen delivery system, which goes to the humidifier. We have set the temperature at 37 degrees. And also the flows per minute is at 60 liters because of severe respiratory distress. And we have also put the FiO2 at 100%. So this is a complete set. This is the humidifier chamber. And then this is the water that we have put to make sure that it humidifies the air. And then the similar settings that you have put down is also what you adjust here, so that you adjust it at 60 liters to match with what is there. So at the moment, we are giving our respiratory rate as 36 beats per minute as detected by the machine, which is an improvement from about 46 to 50 beats per minute.
So I think at that point in time, you see the importance of the high flow nasal cannula. It helps you prevent pre-intubation. This one, I carried the machine here, but let me play this again. Sorry. Okay.
So this bit.
Okay, so what you see here is actually, this is the nasal cannula, really. You put it on the patient, you secure it very well, and you strap it around. This is connected through, I've already connected this device. This one goes to the wall oxygen. After connecting it to the wall oxygen, you have an airflow, it's an EVO. You put it on from there, and then you connect this, normally airtight. After putting it on, you make sure that the humidifier is corrected. There you see me there adjusting for a new patient. I can adjust the temperature and increase the flow up to about 60, or even this one allows 70 liters per minute. And this same setup here delivers for you FiO2 of 100%. Once you go up, I think I'm trying to focus, but it's just taking me to 36. Yes, so I mean, that is the 36 liters per minute. The FiO2 will be automatically detected once you connect it to the wall oxygen. And once you have set it probably to 36 liters per minute, make sure that also what is being got from the wall oxygen, you adjust it up to 36. So that is basically, and then you make sure that you open the humidifier and you you add there some water which will go into the humidifier container to make sure that the air is humidified by the machine before delivery to the patient. Thank you very much. That is on that video. We go to management of severe hypoxemia, like in this patient who required mechanical ventilation. You need to have a team that is well established in mechanical ventilation, and I think that we have here, even at regional referral hospitals. This machine can deliver you 100% oxygen and provide pressure in addition to oxygenation. So you can have so many other modes, and you can tailor it to the need of the patient, to the different conditions that these patients present with, whether it being sepsis, ARDS, or they have, pulmonary embolism and so on. And it may be the best option for those who are very sick, so that you give them time for the lung to recover. You give them time for the body not to move, to give them, to provide a lot of lactic acid, which will be very difficult to manage if it accumulates. So this one here again is what is provided by Ministry of Health. It's really very simple. You put it on from there. You can see the different modes: volume assist mode, simulation mode. You can see the VT, what we call the tidal volume. You can set it to the weight of the patient. And then those are the ventilator lamp settings. This is the pressure that you can also add, and this machine can also give you some PEEP. But there are so many others which are there. You can set this for a child or an adult. So these machines are very many types which are there, but this is mostly a transport vent. I think once we want to put someone on prolonged mechanical ventilation, we have one which is different for this. Right? This one comes mostly we use it mostly for transporting our patients to the next facility. So you need to be also conversant with the different ventilation modes. I think for those facilities which are there, you can use the volume assist mode, the SIMV, the pressure, so many other things that you can vary based on what your patient is really having and based on what breathing parameters you're seeing on the screen. Unfortunately, this one doesn't have the screen, but the ones I've shown you in the previous video has a screen, and you can easily follow up. And you also need to know how to use them. So basically, that is how that is a short presentation that I've made on this. Really, I wanted to. I don't know if there is time, but I don't know if you're seeing this clearly. This I'm about to stop. So this is the Evo flow machine, but I think we have already seen it the other side, how it works, and the whole setup of how you can use it. What you see here is actually where you vary the oxygen from. So you can set your oxygen here at 60. Make sure that also what is put here on the machine is also at 60. Okay, so you can vary it, and it's a touch screen, so it's really very easy to use and can really be a game changer for your patients who are extremely very sick. Make sure that you manage them before going into mechanical ventilation. Thank you very much, team. I can now put off my video.
Thank you, Dr. Oriba. That was a very elaborate and informative presentation. Dr. Oriba, you are also handling the Q&A session. I believe there are certain questions that were addressed in the chat. If you could please unmute and take us through some of those questions and some of the answers that you gave the participants. So Dr. Oriba, again, over to you.
Thank you. I think I will go with I think someone asked a very important question, that what do you really see? Someone asked the question of pulmonary embolism and what we see on point of care ultrasound scan. And I think this has implication for our practice. I think we should be, and I've answered there, the point of care ultrasound scan is actually one of the techniques that we want every healthcare worker to learn. so that in the facilities which they can make this diagnosis, they can help a lot. Like in point of care ultrasound scan, you can see right ventricular dilatation, which is there like in this patient with pulmonary embolism. You can see hypokinesia of the right ventricular free wall, and you compare it with that of the apex. And that is what we call the mechanical sign. And at the same time, you can see bulging of the right ventricle with the reduction in the size of the left ventricle. So yes, point of care ultrasound scan is highly important and diagnostic in patients with pulmonary embolism. Going to the next question, is revised Geneva criteria still used to score OITS Wells criteria? Basically, it's about subjectivity. I mean, I am more well versed with the Wells criteria because I read a lot about it. But the Geneva criteria also is very okay to use as long as you are well versed with it. It's a subjective thing. What are you well versed with? All of them will tell you PE less likely, PE more likely, and what you are supposed to do in the next step. Yes, so the criteria for diagnosis of PE, again, we don't need to cram this. We don't need to cram the Wells score and the rest of it. These scores are available online. If you have a patient that has PE, you probably want to take a detailed history of their travel, recent history of immobilization. Are there features of DVT that you want to tease out? And is the diagnosis of PE more likely in this patient? Based on what you guys have simulated very beautifully for us here, the diagnosis of PE was more likely, so you would score this patient a point of 3. And so if all the scores are 4 and below, then PE is less likely. But if the scores is above 4, okay, then PE is more likely, and you are likely going to do certain tests and start the patient on medication. Yeah. Someone also asked me that, is it important to start, why delay intubation in these patients? We should have intubated immediately. It's very important, to follow up the algorithms that the team has exhibited here is very, very good. And this is what we actually go through. You'd have to stay calm in an emergency situation, let your mind be open to other things, because during the process of making the final diagnosis of PE, you are likely going to find something else which you will correct. And the team has gone through all the processes, which also included resuscitation. Patients with pulmonary embolism can easily, because of right ventricular dilatation, and you want to go directly into mechanical ventilation without resuscitating them, you're going to cause profound right ventricular collapse, which is due to reduced venous return because of positive pressure ventilation, which is provided by mechanical ventilation. So it's important that we follow the algorithm. And I think this is a very beautiful thing. I've learned a lot on how you should maintain your stamina in an emergency situation, so that you make the right diagnosis and you don't miss anything. And the team has done everything. Please, guys, no shortcuts. Don't rush for mechanical ventilation. Follow everything correctly. I'm reading the questions slowly, but I think if you're seeing it before me, maybe I'm seeing there are too many. But I also request someone to help me. I've been giving my talk here, so I see like the questions have really increased so much. Let me check.
Dr. Riba, thank you very much. The team here has taken note of your positive comments. This team is part of the emergency medicine team. We have an emergency nurse here, that is Angel. We have emergency medicine residents, and myself, an emergency medicine physician and an educator. So we are usually in the emergency space, so we've mastered the art of keeping calm and managing the patient. So thank you for noting that. So members online, we're going to give a chance to 2 participants to ask questions. So put your hands up, members online. Anyone who has a hand up? Mulunji Jonathan and Flavia Bagatia. We shall start with Mulunji Jonathan. Please unmute and ask your question.
Okay, yes, thank you so much. I hope you can be able to hear me. Yes,
Yes,
my question is, my question is in relation to massive PEs. At what time, under which scenarios do you use the thrombolytics, and of what superiority are they over the DUACs or the anticoagulants in management of massive PE? Back to you. Thank you.
Dr. Riba, I hope you've had the question in scenarios of massive PEs. When do we use thrombolytics? When do we restratify? And when do we choose them over DUACs? Over DUACs, yes. So Dr. Riba, over to you.
Thank you very much. Wonderful question, because also now we have thrombolytics available. And I think one of the things that you have to do is you have to make sure that, first of all, your patients have the criteria for thrombolytic therapy. And in that case, you score them. And then you look at some other score, like the same 2 score, you look like the Chadvas scores in these patients. But in most cases, yes, administration of, if you find that their scores are good, then you can start them on thrombolytic therapy. But also, we look at patients with pulmonary embolism. Normally, you don't want to start them with the DOACs immediately. So probably the use of low molecular weight heparin and unfractionated heparin is indicated in these patients. But if you have no contraindication to thrombolytic therapy, please administer thrombolytic therapy in controlled doses, and while you are monitoring the patient in ICU. There are contraindications. Someone has had a recent stroke, probably hemorrhagic stroke, and they have bleeding disorders and the rest. So you have to really go and follow up that history very well, look at these patients very well, and probably offer them timely administration. DOACs are still very important on discharge for patients with PE. But of course, it has some importance in patients with PVT. I wouldn't expect someone to start a patient on directly acting oral anticoagulants and they have pulmonary embolism. You know, you need to be very aggressive with this patient. Start intravenous or subcutaneous medication. Intravenously means you can give unfractionated heparin. Subcutaneously, you can give low molecular weight heparin, and normally in higher doses as you monitor them. I think that's what I can say at this point. Thank you.
Thank you, Dr. Riba. Flavia, your hand was up. Let's hear from you. Flavia Bagatia, please unmute and ask your question. Flavia Bagatia, if you can unmute and ask your question. Okay, I think Flavia is not online. All right, anyone else who has a question to ask the team? Anyone else who has a question to ask the team before we move on? I don't see any hand up. So members online, we have Jonas. Jonas Kamati, please unmute, introduce yourself, tell us where you're from and ask your question.
Yes, good afternoon, team. My name is Jonas Kamati, all the way from Namibia. I'm an advanced life support paramedic, and I just have a couple of questions to the team. Firstly, thank you for the good presentation. The first question I have is I wanted to know with the patient diagnosis made at the referring hospital, why was the cath lab team not informed at the receiving hospital for them to be ready to take on the patient? As this should have even eliminated the chances of possibly intubating the patient, because the patient what need or the underlying etiology is embolism, which need to be lysed. So why did you not go through that route of alerting the receiving hospital of the patient that is coming prior to arrival at the hospital? That is the first question. The second question I have is regarding the choice of medication during intubation, or before I move on, is I have seen that when the doctor were intubating, there was no apneic oxygenation during the intubation process. There was no apneic oxygenation. Why was that not done? Why was not considered? And even the optimization of oxygenating, pre-oxygenating was done after giving the medication of midazolam and fentanyl. Why was that? And the third question would be then, why midazolam was used in this patient, seeing that the patient was hemodynamically unstable, and the midazolam is one of the enemy of cardiovascular effect. Why was it given in this patient? And the last question is the level of care, the ambulance care that transported this particular patient. What level of care was this patient transported? Like, who transported the patient? Which level of care? Those would be my, the last one, sorry, is the post-intubation sedation after intubating the patient. Why was there no post-intubation sedation established? Thank you.
Thank you, Jonas, all the way from Namibia. Thank you for tuning into this echo session. We shall handle the question step by step. First, by answering the first question. So here in Uganda, the way the health system is structured, we follow a referral pathway, right from health center 4 to general hospital to regional referral to national referral hospital. Ideally, depending on the level of care, the resources in terms of human resource, equipment, and supplies, the patient goes to the referral system. We simulated this case that this patient was moving from a regional referral hospital where the level of care was not adequate enough for this particular patient. This patient, like you said, needed to be lysed, but also we needed diagnostic accuracy, of which a CT angiogram would give us, which is the gold standard to diagnose a pulmonary embolism. The team from Ginger had their suspicion. However, the reason for referral was advanced care and diagnosis. But we all know that in the emergency setting, never take an unstable patient for radiology. This patient was unstable. This patient was not fit to go for a CT scan. So the moment the patient arrives at the National Referral Hospital, stabilization had to take place. And then after the stabilization, then the decision was then made to take the patient to ICU and then to the cath lab. But at this point, the point of care ultrasound was already adequate enough to make the diagnosis. In regards to pre-referral communication, the referral form in our setting was enough notification. However, in practice, what happens is that in Uganda, we have regional emergency coordinators who then communicate to the receiving facility in some instances where the patient requires highly super specialized care, and this is then prepared beforehand. However, for this particular case, we did not simulate that. I'm going to ask Dr. Paul to answer the questions about the intubation. The questions were around the use of midazolam, but also post-intubation sedation in regards to maintenance.
Okay. Thank you very much for those very good questions. About about the pre-oxygenation, why we chose to pre-oxygenate our patients after giving the sedatives is because you realize that most of the PE patients are never comfortable when you put them in a flat position. So we decided to first allay the anxiety of our patient, sedate our patient, and then we bagged our patient. But we realized even upon bagging, the SATs were not improving. In our simulation, our patient improved up to around 88. So we realized that even if we continue bagging, we shall not get to where we want. So we opted to go in and intubate this patient. So that's why you see, we first gave the fentanyl and the midazolam. First, got the patient into a flat position, gave the ketamine, and we gave the saxomethonium when the patient was in a flat position. Basically, when patients are hypoxic, they are in a state of anxiety. And that's one thing that we always worry about these PE patients. Secondly, our choice of midazolam. We were comfortable giving midazolam because we had already connected noradrenaline. If our patient's heart rate wasn't very high, we would have used a dose of push adrenaline. But in this case, we opted for noradrenaline because of the heart rate of our patient. So adrenaline infusion running, we were comfortable to use midazolam in this patient. The post intubation sedation, since we were moving the patient to the ICU, we felt there was no need to mix medicines in the ED. So this patient is going to the ICU where everything is going to be mixed and will be put on an infusion there. So we found it very comfortable to just immediately after intubating, ICU is aware and we were ready to move in the next 5 minutes, which we felt was very comfortable for us because the doses that we had used during intubation were still in action for this patient. Thank you.
All right, I'm going to close our Q&A session. Participants online, like I said from the start, this is a very special echo session. Why? Because it is the 100th echo session. So that is a very big milestone for us. And like I mentioned earlier on, that these echo sessions are brought to you by SEED Global Health in collaboration with the Ministry of Health, but also from the Emergency Care Association of Uganda. We are privileged, we are honored, we are blessed to have with us very important people here with us in the room. We have the Director of SEED Global Health here with us. We also have the Commission of Emergency Medical Services. And so I will hand over the mic and the screen to the team at SEED Global Health to then introduce our chief guest here. So over to you, Irene.
All right. Thank you so much, Doreen and the team. Really, today is a special day, 100 sessions. I can't believe because it was just yesterday when we had our first session in 2021. So congratulations to you all and to all of us. I can't believe that, we've been able to have all these sessions and still today, after 100 sessions, we have over 350 people participating. I think this is, I don't know whether it's a miracle or what. It's really unbelievable, and we could not have done this without you, our participants. I know many of you have been there since 2021. You've participated, you've engaged. I remember in the beginning, we used to say, invest in yourself. You put in these 2 hours of your time. But at the end of the day, it's really not to get CPD points or whatever, but really to improve the care that you provide our patients. We know we are training specialists, but it takes a while to train a specialist. But in the meantime, all of us have put in time to be able to improve our skills, but also improve the care that you're providing. And for me, as the country director of SEED Global, it really gives me a lot of joy to see that we are committed to this. The other, initially we thought this would be only for Uganda, but as you can see, we are reaching Kenya, Namibia. I had somebody from Namibia, asking very good questions. So we are going beyond the boundaries of Uganda and really trying to improve care across the continent and maybe beyond the continent. So in addition to our participants, really the other team that I would like to thank on this special day is our experts who volunteer and put in time. I can imagine the time Dr. Doreen and team took to prepare this simulation. It's a lot. So they really, really deserve a huge hand clap and thank you. We hope that when we invite you for the 200th session, you'll still be able to come. Yeah, and then of course, this doesn't happen overnight. There's a team, a special team that prepares these sessions, that identifies the experts, sends us emails. My inbox is always full of emails, people reminding me to attend the session, and I'm sure as all of you, so the secretariats as well who volunteer their time to make these sessions happen. A very huge thank you. And of course, last but not least, to our partners, the Ministry of Health. We could not have done this without you. You know that, you're supporting, when you do the supervision, you're asking about, continuous development, encouraging people to participate. So this is really, really a testament of your collaboration and partnership that we would not have been able to do this. So with those many words, I would like to congratulate all of us for this milestone, to everyone who has participated today and those who participate in the other sessions, and also invite our chief guest today. He was here when we were inaugurating, and I'm so happy to see that amidst the many commitments, he's been able to witness this milestone. So Commissioner, you're welcome. Thank you.
Thank you, our Country Director, Irene, for hosting us, the mentors here, all the team that has really presented the cases all through, the SEED Global technical team, and all the members online who have been active participants in these eco sessions. Good afternoon to you all. I'm Dr. Onya John Baptist Nambohe. I work as the Commissioner for Emergency Medical Services at the Ministry of Health. I come here to represent the top management of the Ministry of Health, and I bring greetings from the Permanent Secretary, Dr. Diana Twine, and the Director General of Health Services, Dr. Oraro Charles, who have been very key in supporting our capacity building projects. Emergency Medical Services Department is a new department in the Ministry of Health. And when we were beginning the eco sessions, we had got to discuss, and I remember it followed immediately after COVID. The coincidence, I think, was very peculiar, and I remember closely that we had a breakfast meeting with the then country director, Dr. Bonaventure, and he introduced this idea, which I thought it was something which may not work out very well, but I said, let's give it a try. So when he moved on, Sister Irene took over as the country director, and we continued again managing. And today as we come here, of course, sometimes under echo is not echocardiogram. Echo is the extension for community health outcomes, and it was developed by an emergency, was it a surgeon or physician, who, when he was attending to his patients, he realized that he can't finish all the patients. Patients had a very long line lining up to see him. And he said, what can I do? So he decided that I'm going to build capacity in people who, in their various locations, wherever they were working. And he kept moving from one side to the other to build, to make hands-on. And later, he could supervise these people virtually, and he realized that it made a difference. This is what was brought to us here in Uganda, and we adopted it, and we want to really appreciate SEED Global for having this thinking, which came in line. Specifically, we had the key inputs which were structured this, and these were to make sure that the lead experts are available who can be able to mentor the providers at various levels. We also ensured this online communication, this communication system was not easy. It had to be set up, and we realized that we could be able to reach across the country. And it is amusing that we are not only reaching across this country, but we are reaching almost the region and globally. And it's a very great step. Also, the other input were the health providers themselves, the health workers at your various workstations. If you are not there, this can take place. And there was a lot of advocacy to make sure that all of you can log in. I was amused yesterday when Jimmy was giving me some of the statistical achievements, and on this 100 session, I did not know that we had already kicked 100, but he told me we have reached 100 and say a great achievement. Essentially, is it called essentially? Sentinel session. So it's a Sentinel session, the 100th session, and with so many participants, we have covered across the country, each district we have 146 districts in the country, and we have covered all of them. I want to thank you for that great input. We have reached almost, I think, more than half of the health facilities in this country, and we want to say thank you to all of you who have participated. I was informed that we have reached over 66 countries across, and we are grateful. Thank you people for trusting us to reach that level. And in terms of outcomes, we realize that these sessions have made a change. The assessment indicates that there was knowledge acquisition. Yeah. And we want to thank you so much that people doubled their knowledge. I don't have the actual number here, but I think it was from about 23% to about 60% change, and that is more than doubling our knowledge acquisition. And also there were skills, because these simulations help us to pass on the skill to the people there, and the teams out there were testifying to this effect. And to crown the results chain, actually we say, then what? The change which has taken place from the researches which we have done, we did health facility assessment with the SEED Global Health, we did a midterm review of the strategic plan of EMS with the World Bank. And all these have shown that there is a reduction in mortality. When we did the assessment survey, we did, Dr. Andrew knows very well, we compared in the 10-year, and there was a reduction in mortality by 50%. And that is significant. That shows that The skills which are being built here are making the change we do require. Again, the Uganda Demographic Health Survey has indicated that most of our mortality indicators have improved. The maternal mortality ratio has gone down from 336 to 189. We have had the under 5 mortality rate reduced from, I think, 56 to 40. And we have had a reduction also in the infant mortality rate. And these are not mean figures. We have made a contribution. And I want to tell you that our assessment as EMS indicated that, like in maternal health, 66% of the transfers of mothers were done using a standard ambulance. And that is contributing to improving the delay too. And we want to think that that eventually contributed to the reduction of maternal mortality in the country. Then I would like, as I go towards the end, to appreciate the country director here, Ms. Irene Atuhaire, for her commitment. She has committed to fund almost all these sessions, all of us, to ensure that all this is continuous. She has provided the knowledge which we require. She has encouraged almost everyone. When you say you are about to give up, she says, oh, wake up, the expression is like this. So please let us appreciate her for it. Now I want to appreciate the lead mentor here, Dr. Doreen. We want to say it is not easy. Already, as Irene indicated, it is out of your commitment that we have been able to sustain all the mobilization of all these mentors who have been helping. You know, it is not easy to have medicine experts commit themselves to pass on the knowledge, but she has been there. She's a guru. I think that's why you became even Madam President and all the things. We want to thank you so much for it. All the experts from 2021 to date, I want to say thank you. You provided your time, you educated us, and we are grateful. I want to thank the residents. You have been here, you have demonstrated, you have stimulated most of these, and it brings us to life. The actual passing on skill is when we see. When you see, you feel, and when you touch, you complete. And that, I want to thank you so much that you come here to demonstrate, and that increases knowledge in yourself and to the people you are educating. We want to thank you for that commitment. I want to thank also the paramedical team. The paramedical team have been following almost all the sessions. I usually want to assess who are the experts who are there. And I've realized every session, at least there is a paramedic. I want to thank you for providing that time. Sometimes people are asking me so much, why are you advocating so much for these new professionals? We can be able to do the work. But I say no. There is a gap. And when we say we need emergency care trained people, we are not just saying for nothing. There are skills which one acquires because you are working in a short time. You need to be crisp, you need to be fast, you need to have these skills near you, and they are provided through these trainings. So I want to thank you, and finally to thank all the health workers across the country who have been good participants, and now not to forget the people who fund you. Irene. We want to thank especially Dr. Vanessa, Dr. Vanessa, the lead. I don't know the title very well, Chief Executive Officer of SEED Global Health. We want to appreciate her for this support which she has given for the growth of this. And I want to tell you people that it's not only that, even our scholarships for emergency medicine, SEED Global. So we are grateful. And to all people who support SEED Global, globally, we appreciate all of you. Thank you. And I want to say, let's continue carrying on. And as the country director said, we are pointing towards the next 100 sessions. Thank you. May God bless all of you.
Thank you, Commissioner. Thank you, Irene. Members online, this is an eco birthday, for lack of a better word. 100th birthday, 100th eco session. With every celebration, there has to be something to commemorate it. In front of us, we have a cake. Unfortunately, you're going to enjoy the cake virtually. We shall cut the cake for you, and we shall share the cake for you. So I'm going to ask the cake to be brought in front of our commissioner, who will cut the cake with the team here. Members online, you can put on your cameras. I'm seeing Caroline, Alfred, Ismail, Ronki, Chigozi, Dr. Riba, we see you as well. Let's all put on our cameras. To la show. Dr. Riba, we are sending. We'll send you. Members, let's put on our cameras. It's our tradition to take a photo. Yes, I'm seeing some familiar faces, common faces. Joseph Odula, I see you. Treasure, I see you. Chigozi, we are seeing you. Okay, so as we had mentioned, this is the eco birthday. We shall cut the cake on your behalf. We shall ask Commissioner to please cut the cake with Irene as the country director. Participants, please come. Experts, please come. Experts, paramedic, residents, please come. Okay, so we shall count down to 5, 5, 4, 3, 2, 1. Congratulations. Thank you all. Thank you. Thank you, all of you. Members online, let's take our picture. Taking our picture.
Yeah.
All right. Thank you very much. Yeah. Thank you, everyone. Greetings from SEED Global Health, and have a good evening. See you next week. Have another next week. Yeah, that week.
Yeah.
We are done.